The topic for today's discussion is ACHALASIA CARDIA. ACHALASIA is a Greek word which means failure to relax. ACHALASIA means failure to relax. Its prevalence is 6 in 1 lakh population, and it is more common in females when compared to males. Coming to etiology. Exact etiology is uncertain, but it's postulated that it occurs because of selective destruction of inhibitory neurons. It occurs because of selective destruction of inhibitory neurons occurring due to viral induced autoimmune effect. It occurs due to selective destruction of inhibitory neurons due to viral induced autoimmune effect. It may also occur in parasitic infections like Chagas disease. It may be seen in association with Algrove syndrome. It may be seen in association with Algrove syndrome. Coming to pathophysiology of ACHALASIA CARDIA. When food passes through the esophagus, there will be relaxation of lower esophageal sphincter so that food enters into stomach. Whenever there is failure of relaxation, food doesn't enter into the stomach, leading to absence of normal peristalsis. Because of this, there will be dilatation of esophagus, the food particles and the secretions which are all present in the esophagus because of the hydrostatic pressure. It empties into stomach. Since food bolus is not accompanied by its air, there will be no airflow levels in most of the cases in ACHALASIA CARDIA. Since bolus is not accompanied by its air, no airflow level is seen in ACHALASIA CARDIA. Here we can see that there is absence of fundic bubble in a case of ACHALASIA CARDIA. Coming to clinical features of ACHALASIA CARDIA. It is characterized by triad of dysphagia, regurgitation and weight loss. It is characterized by dysphagia, regurgitation and weight loss. This dysphagia, it is progressive and it is more common for liquids when compared to solids. Other clinical features, it includes halitosis. Because of the undigested food particles which are present in esophagus leads to bad breath or halitosis. Retrosternal chest pain, nocturnal coughs, all this. Patient will take small feeds. Along with this, patient will have huge volumes of water, so that because of the large amounts of water, the feeds get emptied into stomach. Coming to ECOT score. ECARD score helps in assessing severity of the symptoms and assess post-treatment outcome. It helps in assessing the severity of the symptoms and post-treatment outcome. It includes dysphagia, regurgitation, retrosternal pain and also weight loss. The maximum score is 12. Coming to the complications of achalasia cardia, it includes aspiration, pneumonitis, and there is risk of cancer. Over a 20-year span, there is 8% risk of squamous cell carcinoma in case of achalasia cardia. Coming to investigations or diagnosis of achalasia cardia, X-ray shows absence of fundic bubble. X-ray shows absence of fundic bubble. On upper GI endoscopy, we can see frothy saliva in esophagus, undigested food particles in esophagus, and we can see dilated esophagus. Normally, in case of achalasia, upper GI is done to rule out pseudoachalasia. That is occurring because of gastroesophageal junction tumors or strictures. On barium swallow, it shows bird beak appearance. Here we can see the bird beak appearance. This is bird beak appearance. There is dilated esophagus. Here there is dilated esophagus and constricted part. This is lower esophageal sphincter. Coming to the definitive investigation for achalasia cardia. The definitive investigation for diagnosing of achalasia cardia is high resolution manometry. High resolution manometry. It shows median integrated relaxation pressure more than 15 mm of Hg and also absence of normal peristalsis. It shows median integrated relaxation pressure more than 15 mm of Hg and also absence of normal peristalsis in case of achalasia cardia. Coming to management of achalasia, there is no therapy or cure for reversal of neuronal degeneration. The management is symptomatic or palliative because there is no cure. Coming to different management methods for achalasia cardia, it includes medical management, endoscopic procedures, and surgical methods. Medical management includes calcium channel blockers and 5-phosphodiesterase inhibitors. These drugs helps in reducing lower esophageal sphincter pressure, therefore helps in alleviating of symptoms. They have adverse side effects, therefore used in patients who are unfit for endoscopic or surgical procedures. They are used in patients who are unfit for endoscopic or surgical procedures. Coming to endoscopic procedures, it includes botulinum toxin, this botulinum toxin, it helps in inhibiting presynaptic release of acetylcholine. Presynaptic release of acetylcholine from nerve endings, therefore helps in relaxation of lower esophageal sphincter. Its effects are temporary. Its effects last for few months, and after that the patient again gets the symptoms. Therefore, it's not the first line management, and they are used in patients. Botulinum toxin is used in patients who are elderly with comorbidities. Second endoscopic procedure is pneumatic dilatation. Here, expanding of lower esophageal sphincter is done using non-compliant balloon. Here, serial dilatations of lower esophageal sphincter is done in graded manner. Larger balloons increase risk of perforation of esophagus. Therefore, it needs surgical backup when pneumatic dilatation is done. When larger balloons are used, there is risk of perforation of esophagus. Therefore, need surgical backup. Coming to surgical methods for management of achalasia, it includes modified Heller's cardiomyotomy. Modified Heller's cardiomyotomy. Here, muscle is cut in the anterior direction, that is, anterior myotomy is done in most of the cases. That is, muscle is cut both in esophagus and at the cardia. In esophagus, at least 6 centimeters is cut. At the cardiac region, at least 2 to 3 centimeters is cut. After modified Heller's myotomy, the most common complication we can encounter is GERD, because we are cutting the muscle. Therefore, regurgitation of food occurs from stomach into esophagus, which is seen almost in 40% cases. To counteract this, fundoplication needs to be done. It can be anterior fundoplication or posterior fundoplication, but 360 degrees or Nissen's fundoplication is contraindicated because it increases the resistance to outflow of food. Coming to newer methods in management of achalasia cardia, that is POEM, per oral, endoscopic, myotomy. It involves entering into mucosa just proximal to intended myotomy. After this, endoscope is passed in submucosal plane and myotomy is done. It also has increased risk of GERD. Another method in management of achalasia is esophagectomy. It is done in patients of end-stage achalasia with megaesophagus not responding to other methods. It is done in patients of end-stage achalasia with megaesophagus who are not responding to other methods. That is, they have tried endoscopic methods and they are failed, and they have tried surgical methods and they are failed, and therefore esophagectomy is done in those patients. This concludes the topic of achalasia. Thank you.